What about comorbidities here? Do the patients with comorbidities actually require more intensive care, more aggressive care early on? Is that simply an obvious fact? Am I asking a silly question?
Well, I think that when they have more health problems, that's one of the challenges for payers, I think, as well. We know that that comorbidity in general in the U.S. is a major problem. People don't have one chronic condition, but 2 or 3 chronic conditions, and that ends up increasing costs dramatically. Psoriasis patients often have other psychiatric comorbidities, anxiety, depression that commingle with the disease, as you can imagine. Those are also things that end up being costly to the healthcare system.
So just one question, and I don't know this information. So if you say somebody comes in with just a significant outbreak of psoriasis and they have metabolic syndrome, if you aggressively treat the psoriasis, will it also positively impact their metabolic syndrome? Will they?
I was going to ask that next. Darn it.
Well,
I'm glad you did.
Peter. I mean, you take your pick.
Yes, we need somebody to devote their life to that. Wow, we have someone.
That's right, yes. Well, I think that, certainly in the cardiovascular field, the inflammation as a causal risk factor for cardiovascular events has been a matter of intense study. Recently, Paul Ridker had a seminal finding showing that a biologic that targets interleukin-1 beta called canakinumab can lower the risk of major cardiovascular events in patients who already had coronary disease. So we now know that targeting certain immune pathways in people at high risk for cardiovascular disease can causally lower risks of events. In psoriasis, it's more challenging to figure it out because you'd have to do a randomized controlled trial in 10,000 people and follow them for 5 years. We just don't have that type of data. What we know so far is that from observational data with TNF inhibitors, which have been around for 20 years now, that patients who go on TNF inhibitors tend to have lower rates of major cardiovascular events over time compared to patients treated with other agents. It'll take longer term for that same data to emerge with therapies like IL-17 inhibitors, IL-23 inhibitors, IL-12, 23 inhibitors, and what have you, for looking at events.
So the short answer of, do you take into consideration metabolic syndrome when dealing with psoriasis is yes.
Absolutely, particularly when it relates to some of our other therapies. So methotrexate's often more complicated to use in people who are overweight or have metabolic syndrome. They just get into more trouble with the liver function issues.
From your perspective, do people with comorbidities fit into a different strata in terms of their reimbursement plan? Do you carve out for them differently?
I don't think most of the time we get that kind of data, nor do most of the, if you will, the medical policies account for. So for example, if you're looking at the treatment options for psoriasis, I don't remember seeing that there's a significant pathway down. If they have metabolic syndrome, you're going to consider them in a different bucket, if you will.
Okay. Does that surprise you?
No.
Why not?
Very little surprises me. I have a questioning attitude about things. So even the improvement that you see with TNF inhibitors, or associated with TNF inhibitors. TNF inhibitors are thought to, or at least one of them is thought to worsen congestive heart failure. So is it possible that the observational data are a little biased by physicians being afraid to put the patients who are at high risk of cardiovascular disease on a TNF inhibitor, so that when you look at the final results, the TNF group did better.
Right, and I think that's a very possible issue going on, especially due to the fact that we have an enormous amount of under-treatment of psoriasis in the broader population. And so there may be some strong selection pressure where really only the healthy patients, the compliant or adherent patients, well-educated, motivated patients are getting these therapies. And, to some extent, this data has been shown in rheumatoid arthritis as well, so maybe that might be a little more reassuring, where the use of biologics is much higher in that patient population, and you see the same cardioprotective effects in RA as you see in psoriasis.
So boots on the ground here. In the office, patients coming in, what are the challenges that healthcare providers face when they're dealing with these two comorbidities, psoriasis and metabolic syndrome?
Well, I think the biggest challenge is really thinking about how well we can manage both, how we can help the patient have a change in health behaviors, or working with their primary care team to be as healthy as possible and have the best outcomes related to psoriasis. So when people are very heavy, they don't respond as well to systemic agents. They tend to lose response more quickly over time, so they may do well, but then have to cycle through multiple biologics. I often talk to my patients about weight loss. I've had had some patients who have BMI over 40, and we see a fair number of those in our practice, undergo bariatric surgery, and it tends to be life-changing for them, and oftentimes will modulate their psoriasis down. There's been a couple of really fascinating reports out there, patients having big improvements in their psoriasis when they go through bariatric surgery. There's one study from Denmark showing that patients who had bariatric surgery had a lower frequency of developing psoriasis in the future. So as we're knowing that weight loss in people who are obese lowers the risk of diabetes and cardiovascular disease, it also probably benefits them with inflammatory skin disease.
Now, you just said something really interesting, and I'm not going to let this just slide by. We were talking about the chicken and the egg philosophy earlier, question, and we weren't really sure whether metabolic syndrome predisposed you to psoriasis or vice versa, but you just said that obese patients who have bariatric surgery have a smaller chance of having psoriasis. So didn't you just answer my question?
Well, the chicken and the egg could walk in the room at the same time.
But in this case, I've got an egg and you operated on it, and that chicken never showed up.
That's exactly right. But I think both sides of the coin can be going on. Both issues can be at play.
Okay, but seriously, I mean, if you operate and do bariatric surgery so that they lose weight, and then psoriasis doesn't show up as frequently, doesn't that imply causation?
Well, yeah. I mean, I think that there's certainly a lot of evidence suggests that obesity is an important risk factor for developing psoriasis. But there's also data suggesting that when you have psoriasis, you can develop complications related to metabolic disease, diabetes, things of that nature.
I think the evidence would be strong if you randomized the patients to get the bariatric surgery or not.
Yeah.
Okay.
If you didn't randomize, then you have the issue of, is there anything different about the people that you operate on? Now, I don't operate on people for bariatric surgery, but I've talked to surgeons and they tell me they're very particular about who they operate on. And so
that's why I didn't want to let this just slide by.
Right, but the point is when patients who have multiple comorbid states often are overwhelmed by the healthcare system. They may not know what things are available to them to help them with these conditions. And so the goal is really to make sure that patients get access to evidence-based interventions that can better fit their overall health. And so we know bariatric surgery can be helpful in people with a BMI over 40. There's good data on that.
yeah, and they don't have to have psoriasis to recommend it.
That's exactly right.